Okay, hepatitis C is an RNA virus, okay, which mutates faster than the DNA virus, and because it lacks proofreading, it's prone to quite a lot of mutations. There are 6 viral genotypes, and out of the 6, we have 1 up to 5 in South Africa. The transmission is similar to that of hepatitis B. Needles, syringes, equipment amongst people who inject drugs, needle stick injuries for healthcare workers, your blood products, and obviously we've got safer blood transfusion policies now, tattooing, piercing, and traditional and cultural practices, as well as your sexual risk is also there, and there's a PMTCT risk, which is lower though. As far as the prevalence, we are around a moderate type of prevalence in comparison to other countries, less than 1% in the general population, and about 400,000 people are affected. Concentrated hepatitis C epidemics are usually seen in those who inject drugs. And from Durban's analysis, there was a ranging of 28% to 93% in Durban and 93% in Pretoria. A third of people injecting drug use, with injectable drugs rather, have hepatitis C and HIV co-infection were found in the Pretoria metro, all right? What we need to understand about acute hepatitis C virus is that it has a higher potential to becoming chronic. About 60% of those who are acutely infected will progress to chronic hepatitis C, and it's more silent and asymptomatic, often an incidental finding. Those who are acutely infected, 30% of them will resolve completely, okay? 75% of your chronic hepatitis C viral infected patients will then move into your stable, slowly progressing infection. And those who develop cirrhosis from the chronic hepatitis C patients would be about 25%, 95% of which would have your stable compensated cirrhosis. And for those who have cirrhosis, within less than 5% per year will have the decompensating cirrhosis or hepatocellular carcinoma. Diagnosis of hepatitis C as opposed to hepatitis B is much more simpler. Like we said, we essentially just looking for the antibody to hepatitis C, okay? When a patient is screened and their antibody test is positive, you do a confirmatory molecular test, and if that is positive, which is obviously analyzing the nucleic acid, if it's positive, the active hepatitis C infection is confirmed. The patient who is screened with an antibody test and becomes negative, it completely excludes the presence of the infection. And those who have a negative confirmatory nucleic acid test, they would be termed non-active infection patients or those who have a previous infection which has now cleared. All right. As far as management, you need to assess the patient for fibrosis using the APRI score that we spoke about. Look at whether the patient is also HIV co-infected, and there are medications that can be used for treating hepatitis C, and we must be quite cognizant of the potential drug interactions that there may be. Providing secondary prevention services for people who are injecting drug use is important, which includes your sterile injecting equipment, as we said, as well as the opioid substitution therapy. We have to then refer patients for treatment with DAAs, which are your direct-acting antivirals. These have been submitted to SAPRA for approval, at the moment only available as part of Section 21. And if we look at the impact then of the co-infection hepatitis C and HIV, there's accelerated rate of hepatitis C related to the liver fibrosis. If you're HIV and hepatitis C co-infected, progression to cirrhosis increases by up to 3-fold. The relative risk of decompensated liver disease increases by 6-fold, and hepatitis C occurs earlier and is more aggressive in terms of the cirrhosis. An increased risk of mother-to-child transmission is also there when you are HIV and hepatitis C viral co-infected. HIV confers greater risk of acute hepatitis C infection and reduces the chances of clearance. Are we good? Hepatitis C. Then we have hepatitis A, D, and E. When it comes to hepatitis A, the transmission route is fecal-oral. Largely, your patients will be asymptomatic and they would require supportive treatment. Hepatitis D patient is a defective and incomplete virus, and it depends on hepatitis B for its replication. So in South Africa, hepatitis D seroprevalence is actually less than 0.6%. Same transmission route as hepatitis B because they're codependent. Hepatitis E is also fecal-orally transmitted, largely asymptomatic, especially in childhood, severely symptomatic in your pregnant and adults, and they will require supportive treatment and even hospitalization. So in summary, colleagues, viral hepatitis, quite an important issue in South Africa. We have to align ourselves to the World Health Organization targets by 2030. Hepatitis B, C, and D are transmitted by exposure of contaminated blood and blood products, and hepatitis A and B are preventable. Very key message there. Hepatitis B virus birth dose vaccination will be included, and hepatitis B PMTCT program is then going to incorporate that to decrease the burden because this is a high-risk group. Healthcare workers are required to be screened. Catch up your doses. Start your doses if you haven't, but it's quite important that you get vaccinated. All right. Viral hepatitis and HIV co-infection have an impact on each other in terms of increasing the severity of how one presents as opposed to being HIV negative. Hepatitis B and C diagnosis is a basic workup, can be done at primary healthcare level. The analysis of all the antigens and antibodies that I've told you about and management of chronic will be done at a higher level. So it's important, though, as we train, to help our clinicians understand identification, the workup, and when it is important to refer. Okay. Good coverage of needle and syringe services as well as opioid substitution therapy for those who are injecting drugs is very critical, and a range of tools are going to be made available to you, especially the drug-to-drug interaction app that you can download as you manage your patients. Any questions, colleagues? All right. Thank you.